Hello, anesthesiologists. Thank you for your hard work today administering anesthesia to an emergency lung transplant patient. We welcome all doctors interested in lung transplant anesthesia. Hola, anestesiólogos. Gracias por su arduo trabajo hoy administrando anesthesia a un paciente que necesita un trasplante de pulmón de emergencia. Damos la bienvenida a todos los médicos interesados en la anestesia para trasplantes de pulmón. All right, let's jump right in. In this session, we're going to break down the anesthetic management for one of the most challenging cases we face. We'll start with the foundation, the preoperative assessment. Then, we'll move into the high-stakes moment of induction and airway control. After that, we'll tackle ventilation strategies, and we'll wrap up with the complex world of hemodynamics and extracorporeal support.
So, Part 1, Overview and Pre-op. Success in these cases is almost always determined before the patient even enters the operating room. It's all about that meticulous preparation, really understanding the patient's unique pathophysiology. This is where we lay the entire foundation for a good outcome.
To appreciate where we are, it's worth looking at how far we've come. The first attempt was way back in 1963, but it took another 20 years until 1983 for the first real long-term success. Now we're doing over 4,000 of these procedures a year, but don't let that number fool you. The challenges are still absolutely immense.
Because despite all that progress, the median survival is still just 6.7 years. Think about it. The lung is the only transplanted organ that's constantly exposed to the outside environment. That makes it uniquely vulnerable. This number right here really underscores our critical role. Every single decision we make in the OR directly impacts that long-term outcome.
So who gets this precious resource? This table really lays out that difficult decision. The indications are pretty clear-cut, but it's the contraindications where things get nuanced. The absolute contraindications, well, those are hard stops. But the relative ones, like being over 65 or already on a ventilator, those are the gray areas that require a huge amount of discussion and judgment from the entire team. It's a constant balancing act.
And that balancing act really boils down to this. The patient has to be sick enough to absolutely need the transplant, with a greater than 50% chance of dying within 2 years. But they also have to be well enough to survive the surgery itself, with a greater than 80% chance of making it to 5 years. Our entire preoperative workup is designed to walk this very fine line.
This table shows you the factors that scream high risk. When you see a patient being bridged on ECMO, needing lots of oxygen, or coming in with severe pulmonary hypertension, that's a whole different ballgame. Identifying these red flags right away allows us to plan for advanced support from the absolute get-go. No surprises.
And our plan cannot be one size fits all. It has to be tailored to the specific disease. If you've got a patient with cystic fibrosis, you're already anticipating chronic infection and major bleeding risk. For a COPD patient, your focus is on that right ventricle and cardiac comorbidities. With IPF, you're bracing for brittle, severe hypoxemia. And for primary pulmonary hypertension, well, your entire universe revolves around the RV and the near certainty that you're going to need ECLS.
So a deep, thorough workup is completely non-negotiable. Of course, we look at the standard things like PFTs and a CT scan, but a VQ scan is critical for guiding the surgical approach, and a right heart cath is the only way to truly quantify RV function. But what's just as important are the functional and nutritional assessments. These tell us the real story about the patient's physiological reserve.
Assessing frailty has become standard practice, and for good reason. A tool like the Short Physical Performance Battery, the SPPB, it's remarkably simple. We're just testing their walking speed, their ability to get out of a chair, and their balance. But the data it gives us is incredibly powerful. It's an independent predictor of post-transplant survival, telling us more about their reserve than just about anything else.
And look at this chart. It brilliantly shows that classic U-shaped mortality curve for BMI. Being either underweight or obese significantly increases the risk of death. This is exactly why aggressive nutritional support and optimization are a mandatory part of the pre-transplant process. You have to get the patient into that sweet spot.
Okay, let's move into Part 2. Now we see how all that preoperative work funnels into these next few minutes: anesthesia induction and securing the airway. You could argue this is the single most dangerous phase of the entire anesthetic, a moment where a patient with absolutely zero physiological reserve is pushed right to the very edge.
This quote says it all, doesn't it? These patients are living on a knife's edge, totally dependent on a high sympathetic drive just to maintain equilibrium.
Even a tiny dose of a sedative can cause them to hypoventilate. That leads to hypercapnia and hypoxia, which causes a catastrophic surge in their PVR, leading to acute RV failure and cardiovascular collapse. That is precisely why these patients get no pre-medication.
Our monitoring has to be invasive and comprehensive from the very start. A right radial arterial line is a standard, and that's specifically to monitor cerebral perfusion, especially if you go on central VA ECMO. That's where you can get that differential oxygenation, the so-called north-south syndrome. A PA catheter is absolutely mandatory for managing the right ventricle, and of course, the TEE is indispensable. It's our eye inside the heart.
Now here's a key decision point. When do you place that PA catheter? Doing it before induction gives us that invaluable true baseline data, but it can be incredibly stressful for a patient who is already anxious and short of breath. Doing it after induction is much more controlled, but then we lose that pure baseline. It's a judgment call, and you have to tailor it to the patient in front of you. When it comes to induction, we have 3 and only 3 primary goals. 1. Maintain systemic vascular resistance to ensure the right ventricle gets enough blood flow. 2. Preserve myocardial contractility. And 3, which is arguably the most important, prevent any increase in pulmonary vascular resistance. Our entire induction cocktail is built around these 3 principles.
Let's be clear, induction is a planned, controlled cardiovascular crash. We have to assume that collapse is an immediate possibility. So our safety net must be in place before we push a single drug. That means the perfusionist is in the room with a primed ECMO circuit. The surgeon is scrubbed and ready for an emergent cannulation, and all of your vasoactive drips are not just drawn up, they're on pumps, connected to the patient, and ready to go. We have to be prepared to initiate a full rescue within seconds. For the airway, a left-sided double-lumen tube is really the device of choice. And compared to a bronchial blocker, the DLT just gives you so much more. You get superior lung isolation, which is critical. But even more importantly, it allows you to access the non-ventilated lung for suctioning or bronchoscopy during the case. That flexibility is absolutely worth the slightly more challenging placement.
Okay, let's talk about ventilation. This is a constant dynamic balancing act throughout the entire case. Think about it. Before the transplant, we are managing a severely diseased lung with its own unique, difficult pathophysiology. Then we have to switch to one-lung ventilation on that same diseased lung. And finally, we have to ventilate and protect a brand new, pristine, but incredibly vulnerable transplanted lung. Our strategy has to evolve with each phase of the surgery.
This table is so critical because it shows there is no one-size-fits-all approach to ventilation here. For a COPD patient, the enemy is air trapping or auto PEEP, so we use slow respiratory rates and very long expiratory times. But for restrictive disease like IPF, the lungs are stiff and prone to collapse, so we do the opposite: rapid rates, tiny tidal volumes, and high PEEP. Using the wrong strategy for the patient's disease will lead to disaster, plain and simple.
Hypoxemia during one long ventilation is almost a given. So we need a clear, stepwise algorithm. First step, always, grab the bronchoscope and confirm your DLT position. If that's okay, then you can increase your FiO2 and add some PEEP to the ventilated dependent lung. But really, the definitive solution, the one that almost always works, is asking the surgeon to clamp the pulmonary artery. That eliminates the shunt, and just like that, the hypoxemia resolves.
Now, once that new lung is in and reperfused, our entire ventilation philosophy has to shift. The game is now about protecting this new vulnerable graft. So we use a classic lung protective strategy: low tidal volumes based on ideal body weight, keep those peak pressures under 30, use a moderate amount of PEEP to prevent atelectasis, and get that FiO2 down as quickly as you possibly can to minimize reperfusion injury. All right, on to our final section: hemodynamic management and ECLS. This is where we navigate the absolute pressure cooker of this surgery, with our focus almost entirely on the right ventricle. This is where the magic, and sometimes the terror, happens.
And this TE image shows exactly what we're terrified of: acute RV failure. Look at that. The right ventricle is massively dilated, and you can see the interventricular septum is bowed way over into the left ventricle. That septal shift is crushing the LV, impairing its filling, and sending the patient into a downward spiral of hypotension and ischemia. This is the exact picture we're trying to prevent, especially when that pulmonary artery clamp goes on.
So this table is our pharmacologic toolbox for managing that struggling RV. Inhaled agents like nitric oxide are fantastic because they're selective pulmonary vasodilators. They work where we need them to without dropping the systemic pressure.
Milrinone is a great choice because it's an inodilator. It improves contractility and vasodilates the pulmonary circuit. The catch? It also vasodilates systemically, so you almost always have to pair it with a vasopressor like norepinephrine to maintain that crucial RV perfusion pressure.
So here's the scenario. It's the moment of truth. You've maximized your pharmacology, you've got them on nitric and milrinone, but the surgeon clamps the pulmonary artery and the RV just gives out. The blood pressure plummets, you have to escalate, and you have to do it immediately. What is your next step?
The answer, of course, is mechanical circulatory support, and the modern standard of care is veno-arterial ECMO, not traditional cardiopulmonary bypass. The number one reason comes down to anticoagulation. For ECMO, you only need an ACT of about 160 to 200. For full bypass, you're up over 480. That massive difference in heparinization means that with ECMO, you get far less bleeding, fewer transfusions, and ultimately less primary graft dysfunction. It's a game changer.
Now, for those patients who are already on an ECMO bridge coming into the OR, we need a way to quantify their risk. That's where something like the STABLE score comes in. It uses a handful of clinical variables to help predict their chances of post-transplant survival, which is crucial for the team when weighing the risks and benefits for these incredibly sick candidates.
This chart's message could not be clearer. Anticipation is everything. When ECLS is initiated electively in a controlled fashion in a high-risk patient, their one-year survival is far, far better than when we have to use it as an emergency rescue after a cardiovascular collapse. This is why having a low threshold to go on support electively is so incredibly important.
Now, this slide highlights a major philosophical debate in the field right now. Routine versus selective use of ECMO. Some very successful centers put nearly every single lung transplant on ECMO. The rationale is it provides absolute stability in an optimal surgical field. The opposing view is to use it selectively only when a patient demonstrates instability, thereby avoiding the risks of bypass in those who can tolerate the procedure without it. There's no single right answer here, just different approaches.
Finally, at the end of the case, we have to decide whether to wean the patient from ECMO in the OR or take them to the ICU still on support. This is a multifactorial decision. It's based on the quality of the donor lung, the ischemic time, and most importantly, how the patient and the new graft tolerate attempts to wean. Continuing ECMO post-op essentially provides a bridge, giving that new lung some time to recover and adapt.
So, to wrap it all up, what are the crucial takeaways? First, meticulous preoperative assessment is everything. Know your patient inside and out. Second, induction is all about one thing: protecting the right ventricle. Third, your ventilation strategy cannot be static. It has to be dynamic and tailored to the phase of the surgery. And finally, for those high-risk patients, anticipate failure and have a very low threshold to initiate ECLS electively.
And that brings us to a final forward-looking question. As our technology, like awake ECMO bridging, gets better and better, the next frontier might not even be in the operating room. How do we use that time on the waiting list while a patient is on ECMO to actively reverse the risk factors, to combat their frailty and improve their nutritional status while they're tethered to a machine? Optimizing these patients before they ever get to us, that's the real challenge that lies ahead. Thanks for joining me.